Here we go. And we are live. Hello, everyone. Thank you so much for tuning in to the highly anticipated last one of the year, Endotruthslive Endometriosis Expert Q&A. And before we get started in the fun and diving into get reacquainted with our expert panel, I do have a disclaimer to read. So everyone pay attention as you're hopping on. Welcome, and please note that this video cannot and should not replace any advice from the patient's healthcare professional. Any person who's experiencing symptoms should seek an individual professional help for evaluation and or treatment. This video is for information only, and it is not intended to provide individual medical advice. Again, everyone, thank you so much for tuning in. Doctors, thank you so much for your time. Welcome.
Thank you very much for having us.
Thank you.
Okay, so let's get reacquainted. First, we have Dr. Ted Lee. He is the Director of Minimally Invasive Gynecologic Surgery at Mackey Women's Hospital. And he is also the Secretary Treasurer, guys, and the incoming Vice President at AAGL. Now, he is also a 5-time Golden Laparoscope Award winner for the best video, surgical video at AAGL. So Dr. Lee, welcome.
Thank you. Thank you.
We have Dr. Nicholas Fogelson up next. He is the founder at Northwest Endometriosis and Pelvic in Portland, Oregon. He has a particular expertise in the management of endometriosis. And as he broadens and expands his expertise, he is looking at a special interest in neuropathology.
Thanks very much, Brittany, and Joy and all the other people online. I appreciate it.
Absolutely. Welcome, welcome. And last but surely not least, we have the amazing Libby Hopton. She is the founder of Endometriosis. She is a endometriosis research consultant, and she is also the co-host of the Endometriosis podcast. Welcome.
Hi, thank you.
Yes. Okay, so before we begin, I do want to remind everyone that is viewing to share. Welcome. We are so happy to have you. And the founder of Endotruthslive, Joy Roberts, has graciously provided 2 giveaways today. So if you share this and comment during the live video, you will be entered into one of the 2 giveaways. And this one is going to be jewelry, handmade jewelry, her line that she just released, so you don't want to miss it. Thank you to everyone who is participating. We love our Endo fam. All right, so let's get started. We're gonna jump right into the basics. Libby, I want you to take this one for me, please. Let's get back to the basics. What is endometriosis?
I guess the core histopathological definition is the presence of endometrial-like glands and stroma outside the uterus. So usually the most common place for it to be found is the peritoneum, which is a thin lining of the pelvic organs. It's usually found deep in the pelvis, so involving the posterior cul-de-sac, which is the area behind the uterus, between the uterus and the bowel. But obviously not all patients have a histopathological diagnosis. So it might be suspected based on symptoms. It might be highly suspected based on exam if deep disease is present, or if endometriomas, which is a type of cyst, are present in the ovaries, which can be seen on imaging. So it's a gynecological condition and affects around 1 in 10 women, girls and women of reproductive age. And it can also affect women post-menopause, and occasionally men. I guess that's kind of it in a nutshell. And most common symptoms are pelvic pain, pain during menstruation, pain with bowel movements, pain with urination, infertility, and it can also occur in sort of further afield places, less commonly the diaphragm, lungs, but most commonly it affects the sort of tissue surrounding the reproductive organs and the ovaries. And, yeah. I don't hear you.
Brittany, your mic is off.
Thank you. Sorry about that. I was saying that thank you for that explanation. We do have a lot of seasoned viewers out there, but it is so important because we have, I mean, 1 in 10, it's just so many women out there to reach. So thank you for that explanation. Dr. Lee, I have a question for you.
Sure.
What are the largest obstacles in diagnosis for endometriosis? Oh, I'm sorry. What are the largest obstacles to patients receiving care for endometriosis?
Well, I think obviously I'm gonna let focus and mention about getting a diagnosis, but in terms of getting care, I think it's I think access is probably the biggest obstacles because there are not many physicians or not many gynecologic surgeons who are trained to do proper surgery for endometriosis, and there's actually no credentialing body in United States. For most parts of the world, they do not have credentialing body for endometriosis surgery. So a lot of things that people base on would be, you know, a lot of the Facebook group, such as Endometriosis, as well as Nancy's Nook and so on. Unfortunately, a lot of this groups, while they are very good in terms of providing a lot of knowledge and information for the patients, many of the physicians who are actually listed on the group, it's not very entirely clear as to like whether they are actually good surgeons. At times it become almost like a Yelp kind of review for the surgeons, and the patients themselves obviously may not be the best judge of surgical ability in terms of the completeness of the surgery and so on. So it's not the best, but obviously that's the best we have. And there are certainly, I think, ideally there ought to be like ability for us to vet surgeons from other surgeons, as well as from the patients. I think patients, their input in terms of their feedback of their experience with the physicians are very important. But at the same time, we ought to have a better way to figure out, whether different levels of endometriosis surgery. Obviously, we cannot limit endometriosis surgery to only the top 1%, because that would actually diminish access to the most patients who have much easier endometriosis. But at the same time, it would be a great favor to the patients if there's a way for the patient to know the different level of surgery that the surgeon can perform. And so that's kind of one way. Right now is that we do not train enough surgeons to be out there doing the right surgery. That access is a problem, and obviously that's an obstacle. I'm sure other people have, other, thoughts on this whole issue.
Absolutely, I'm sure. And y'all feel free to jump in if you'd like to add anything to that. Dr. Fogelson or
I think, yeah, I mean, I think that I see two different sides of it. One side is that when I look at it from a kind of a global demand point of view, there don't seem to be a lot of like sometimes I go, wow, there aren't a lot of surgeons who are really deeply trained in doing endometriosis work. And part of it is because it's such a long path to becoming good at doing endometriosis surgery. I mean, I first kind of had a thought in my mind that I wanted to do endometriosis surgery as a career over a decade ago. And it wasn't until I did a fellowship and then I spent another 3 or 4 years training with really, really good colorectal surgeons and urologists, and that was in practice after fellowship. Like before I really felt like even ready to be doing any kind of complicated endometriosis work. And then over the last 5 or 6 years, you continue to grow. And now I finally feel like maybe after 12 or 13 years after I first conceived of doing this, that I really can do just about any case that anybody can do. And that's not counting neuropelviology, which is the next frontier, I think, which is, again, you start looking at things that are very difficult. So when you look at potentially a 10-year horizon to really get good at doing this stuff to where really you could do almost any case, I mean, there aren't that many people that are interested enough to actually pursue that. And then there's the unfortunate business side of it, which is that our current insurance system doesn't actually support surgeons to do this. You can't invest 10 years of your life and come out and actually get paid like a doctor that invested 10 years of their life in becoming a cardiothoracic surgeon, for example. So somebody that spends, for example, it might take you 10 years to become a cardiothoracic surgeon. The rewards are far greater in doing that than doing endometriosis surgery. You'd be far better off delivering babies all day than doing endometriosis surgery. And that only takes 4 years of training. And my 10 years was after 4 years of training in how to deliver babies. So, so it's difficult to, you know, and I think when Dr. Lee's talking about the list of sort of vetted surgeons, they're not really that vetted. I think the vetting is that the people that are on lists, they believe in excision, they understand that excision is better than ablation, and they do a certain amount of excision. But when it comes to people that could do really complicated stage 4 cases, there aren't that many. Now I'll just flip the switch a little bit, is that when every now and then we go, wow, there aren't that many people that do this, but then we just went to AEGL in November in Vancouver, and I would swear like it's the endometriosis meeting. Like this is the endometriosis show. There's the it's almost everything at AEGL feels like it's endometriosis, and there's hundreds and hundreds of really, really talented surgeons that are there. But at the same time, that's probably most of the really good endometriosis surgeons in the world are there. So, you know, on one hand, you go, wow, there's not a lot. On the other hand, you go like, oh my God, everybody's so great. And there's so many people. So, you know, if you get them all in the same room, it seems like a lot, but there's a big world to cover.
Well, ideally, that you ought to almost have like a black belt system, you know, that you want everybody to
You
be
definitely
black
have,
belt.
you're like fifth Dan.
First degree to 10th degree black belt, and it will be a objective kind of assessment. That's what you want, but unfortunately, that will never happen.
Well, I don't know why you can't. What I would love to have is a system where, okay, let's have a way where everyone can post their endometriosis surgery videos that are anonymous. It doesn't say who they are, and then other surgeons grade them and just give them scores. And it could be done over time. I mean, you know, the problem is that if I watch Ted Lee's video, I know Ted Lee's 8th degree black belt, and I go, well, it's amazing. But if he has a bad day, I should give it a bad score. So you really need to put the videos anonymously, but it's very technologically feasible, but no one has actually approached that. And nobody really wants to grade endometriosis surgeons. I mean, ACOG wants to say that anybody can do endometriosis surgery, which is of course not true. But the largest credentialing body of the American College of OBGYN has no interest in even accepting that their general 4-year trained doctors cannot do endometriosis surgery. They want to say that they can. And unfortunately, they don't do a very good job at it. Not their fault, but they're just not trained in it.
Libby, what do you think?
I've this idea I've kind of thought myself, like it would be really cool to set up a website with a peer review panel, kind of blinded assessment where, you know, surgeons can essentially anonymously submit their, you know, surgery or even just their surgical photos, and kind of reach, you know, like kind of like completing a level on a computer game can, you know, say, okay, I'm a level 4. I can show that I can debulk a, you know, a rectovaginal nodule or whatever, and where no one really loses, everyone can say, okay, I can ablate a lesion, or I can do this, or I can do that, but where then, and that information can be paired with a way that patients can seek out a surgeon who can essentially manage their case, or, you know,
there is a platform called CSATs that tries to do that, but I feel like there's not a lot of people that review for CSATs that actually know a lot about endometriosis surgery. When I put my endometriosis cases on CSATs, like they can tell you if you do a hysterectomy well, but if you put endometriosis surgery on CSATs, I get a lot of comments from people that I'm pretty sure don't do it as well as I do, because their comments just don't.
Comment is, how come you do so much dissections?
Yeah, you're treating your patient like a cadaver.
Why you're so radical on your dissections? And I was like, well, that's what you need to do. And so that they are obviously, you know, for people to review this type of videos, they need to have actually experts to do that. And unfortunately, they just, you know, people are busy doing surgery who are experts, and they don't really have the time to review the videos. But ideally, that's what needs to happen. And I have suggested that people who are like, you know, semi-retired endometriosis surgeons, somebody like David Redwine or the like, you know, where the kind of like, that would be their way to contribute to the world of endometriosis, for them to review videos and validate the skills of people who are currently practicing, and that would be a service to the endometriosis community.
Yeah. Well, we should talk more. I'm a geek. We could potentially do it. The problem is big websites cost money, but
we need a grant from Google or something like that. I don't know.
Anyhow,
We need to make it
I
public.
love it. Everyone is in on y'all's getting together, putting y'all's heads together. This is good stuff.
I have
What's-
a comment. I'd like to kind of comment and comment on Lillian commented that Dr. Lee, I'm from Newcastle and I've heard wonderful things about you. I'm treating with one of your understudies. We appreciate all the hard work you do to help women with endo. I wish everyone knew about excision specialists. It's kind of a comment, which is a good thing.
Well, thank you.
Absolutely. Thank you for sharing that, Joy. Y'all keep dropping your comments in the comments below. Thank you for everyone. Thank you everyone tuning in right now. Joy, the founder of Endotruthslive, is actually in the comments right now. So she'll see everything that you're commenting and that way you can engage with us. But thanks again for tuning in. All right, so let's switch gears a little bit. Let's talk about diagnosis. Dr. Fogelson, why? Why is there such a delay in getting a diagnosis of endometriosis?
Well, if I were to give you one answer, it would be the number of minutes I had in education during my OBGYN residency in endometriosis. And I would say those number of minutes are probably 30. Can you imagine being called an expert in something that you were given 30 minutes of education on? That's the sad truth, is that everything I know about endometriosis, I learned from talking with people like Ted Lee and all these other colleagues, and from reading. I mean, I got interested in it and I read and read and read. If you don't do that, you just don't know very much about it. And one of the natures of humanity is that the more you know what you don't know. And when you expand your knowledge, you become aware of all kinds of areas of knowledge that you don't possess. And so the people that know the most often think they're kind of in the middle of knowledge, whereas the people that know the least often think they know more than the people that know more. And that's been verified in clear psychological studies, that people who you verify people's amount of knowledge, and the less they know, the more they think they know. And so unfortunately, general OBGYNs and family medicine doctors and everyone else just aren't taught very much about endometriosis. And so they don't think of it. And you get these weird biases where you have enough women that have really miserable menstrual cycles. When it affects 10% of women, that means that 1 out of 10 women that an OBGYN sees has miserable menstrual cycles and has a life that's affected by endometriosis. And you start to think it's just normal. And you get a lot of people who will see a patient and maybe they'll put them on some birth control pills. And if it doesn't work, they kind of just go on with their day and they don't really investigate it. When a physician also is asked from a systematic point of view to see 20 to 30 patients in a day, that means they can give that patient maybe 10 minutes of their time. It's very hard to really in-depth evaluate a patient with pelvic pain when you have 10 minutes to interact with them. And a physician almost like says, oh my God, I got a new pelvic pain patient on my schedule and I don't have time. And so they may just kind of listen a little bit and give them some birth control pills and move on. And it takes patients a lot of time to kind of intersect with a physician that has the amount of knowledge and the interest to really, really evaluate what's wrong with them. I think from a systematic point of view, we don't educate physicians very good on not only endometriosis, or I should say very well, on endometriosis, but also the variety of other things that can cause pelvic pain. And then we don't structurally create a care environment that allows a physician to dedicate an hour of time to evaluating a patient and then having them back and spending another hour with them and then another hour with them, because it takes a lot of time. And you know, so it's a combination of education. There isn't very good education. And I think structurally medicine has kind of moved over time to make it pretty difficult to take care of people that have really complicated diagnostic pathways. People really, the healthcare system expects the doctor to figure it out in 5 minutes, and it's just not true. You can't figure it out in 5 minutes. And then the surgical side of it, again, we just talked about it, it just takes forever to become good at doing it. And not a lot of people that, if you don't know what to do, like there's not a lot of interest in making diagnoses that you don't know how to fix. And so there's a lot of physicians in this mode of put them on birth control pills. If that doesn't work, put them on Lupron. If that doesn't work, they're crazy. And that's the only mode they're in, but that's what I was taught. I was literally taught that as a resident. I mean, people literally said, you know, or take their uterus and ovaries out, And if they don't get better, well, at least they don't, I mean, literally people said, well, at least they don't have pelvic organs anymore and you won't have to see them anymore. As crazy as that is, those words came out of people's mouths that were teaching me. So, you know, to some extent, like those kinds of really dismissing kind of things people would say to patients, you say that to your young learners and you kind of say it in a joking way, but over time people get the message that, yeah, pelvic pain patients are crazy and I don't want to take care of them. And so it takes a physician of a certain personality, I guess, to say, reject that and say, no, I don't, I do want to take care of them and I want to learn. I get to spend my own time in learning. So it's just, it takes a long time. But I also think that it's not everyone's fault. It's not like it's OBG. I think sometimes online you see physicians that are really criticized for not making diagnoses like they're dumb or they're idiots. And that's not true at all. I mean, OBGYNs are well trained. They spend a long time learning what they do. And you know, they aren't going to make the diagnosis any more than I would make the diagnosis of some neurosurgical problem, because I'm absolutely not trained in that. We just have a little bit of a broken system that says that. Yeah, go ahead, Ted. I go on forever. I'm sorry.
I think it's to be honest, I think, you know, to make some, you know, fairly make diagnosis isn't that difficult, and you just have to listen. There are certain things that, you know, that I teach my residents, my fellows, that are very, very basic. Actually, one of my most boring talks, in my opinion, because most of my talks I have a lot of surgery video clips and everything. But one of my most popular talks for me in Surgery U was actually without any video clips. It was just me talking. There was just basically PowerPoint slides and with me talking in the background. And that's one of the most viewed videos of in Surgery U. It was talking about, you know, diagnosing endometriosis from history and exam to the OR, just the whole process. And I give that talk to the fellows probably 3 or 4 years ago. And that is something actually very basic that I think most general OBGYN can watch and learn and be able to pick up the skill set necessary to do the good history and good exam. And so it's really not, and a lot of times I think, you know, showing off your surgical skills, most people are not going to be able to do that. But teaching, I can make much bigger impact with that talk, because I can now teach people how to pick up endometriosis much more accurately and much more sensitively. And so for me, even though that video doesn't have any, that presentation doesn't have any surgical footage in it, but I think it makes the most impact. And it's on Surgery U, but I want to see if I can somehow post it on my YouTube channel.
You know, and doctors are frustrated with their ability to not help women with endometriosis and pelvic pain. And given enough, you know, it doesn't take that much education for them to go, yeah, I want to help them more, and either to get interested themselves or refer more. I mean, I've, you know, when I meet with a group of 6 or 8 doctors in my community and show them some of what we do and talk to them about endo, they will send patients. Like they don't really want the patients, really. They don't really know what to do with their difficult pelvic pain patients, and they're happy to have resources. But it takes that educational effort and going out and, you know, integrating with your community and telling them. And I think particularly in my setting where I'm in private practice, I think in your setting, Ted, I mean, you have a large funnel of patients through a large academic center, but like I did when I was at Emory.
But I think education of basically how to do a proper history and exam is not that hard, and it's something that can be taught on a broader scale. And I think that would help with picking up endometriosis at least. In terms of treatment, that's a different story, you know, because we just don't have enough people trained to the certain level that we require. But obviously, I don't want to be too elitist about the whole surgical aspect of things. But I think because the majority of patients have very simple, easy endometriosis to treat, and then so that ideally that we should have a lot of people be able to do the very basic, lower level endometriosis surgery, and only the ones that require very, very advanced surgery go to the one that has more advanced skill sets. That way, we don't we'll continue to provide access to the patients for the levels of the care they need.
Yes, good stuff. Libby, would you like to add anything? If not, I have a question for you.
Yeah, I think a lot of it carries over into the next question. So I'll just wait for that.
Okay. All right. So during our previous panel, Libby, Daniela commented, during topic discussion of the lack of thorough exam and workup, so many of these doctors, quote, so many of these doctors I see are biased and stubborn thinking when it comes to female issues, where it actually starts with an open mind, not a stubborn one. Question. Do you offer suggestions to both the standard practitioner, who are often the first to hear of the onset endometriosis symptoms, and encouragement to the patients who walk away from that appointment without those symptoms being discussed and addressed?
So I think Nick covered a lot of the core problems. Lack of awareness and training on the part of, for example, PCPs and also OBGYNs. And also that they do see a lot of these patients. I think at one point, I remember reading somewhere that like a third of the patients a PCP will see in a day, an average day, are women with menstrual related, symptoms. So it's very, very common, yet it seems that they don't really know what to do with these patients, or maybe they don't understand that there are things that can be done to help, and or they might believe that there's not much point in referring these patients because they're just going to be prescribed the same thing as they would prescribe, birth control or something similar. So they tend to just, give the patient a prescription and tell them, here, take these pills, and they'll help, and, hopefully not see you again. And that can go on for a long time, because if the one pill isn't well tolerated, they might put them on something else, and so on and so forth. And the patient might become disillusioned and not really go back, because if they're not being helped, then why would they go back? And if they don't feel they're going to get anywhere, and in many cases, depending on your insurance, depending on where you live, PCPs can be the gatekeepers really to the healthcare system. And I guess in a way, OBGYNs can too, because even if you are referred to a gynecologist, you won't necessarily be referred to someone who has much expertise in endometriosis, and then that's a further step. So it's a really difficult situation. I do think basic information, I think what Ted Lee mentioned about, just being able to do, it would be cool if they're, so for interstitial cystitis, as the puff questionnaire, if there was something like that, a clinical instrument that could be very simple for a basic, PCP to use to sort of evaluate for risk of endometriosis or a similar problem whereby the patient's going to benefit from seeing someone who has more expertise, that might help, get these patients the care they need in a more timely manner. I also think from the patient's perspective, often patients are told in social media, oh, just seek a second opinion, which might help. But if you're restricted and, you have to see a PCP and that PCP has to refer you, seeing another PCP is, you might well just encounter the same problems, or you may not easily be able to see someone else. And so you really need to find a way of getting what you need through that person, your provider. And in that situation, I would say, really focus on preparing your questions, prepare for your visit. It can be very overwhelming, especially if you've been to this person before and they're not helping and you're desperate. I mean, that's a very overwhelming situation. Take someone to advocate for you if that helps and if it makes you feel more comfortable, and give concrete examples of how this is affecting your life. So, make it very clear, I'm missing work every month, or I'm in bed for several days a month. I can't care for my children. I can't keep up with the normal things. I'm not able to have sex with my partner because it's too painful. If you can give these concrete examples of what a devastating effect it's having on your life, it will hopefully bring home more, okay, this patient, her quality of life is really impacted. We really need to do something, versus, oh, it's just period pain. She's just having a problem with being a woman, or, just dealing with the normal things. And, oh, it's just, this is the 10th patient today. And, oh, I need to get her out of my office. So I don't know. I think if you can try to keep a pain diary if helpful, try to sort of, in as objective terms as possible, demonstrate the impact it's having. So it's harder for them just to sort of brush you off. And don't blame yourself, because obviously this is a situation that women and patients with endometriosis are experiencing the world over, and it's an unfortunate one. And hopefully it will change, but obviously it's a complex problem due to various things. Well, yeah.
Absolutely. Well said, Libby. Doctors, would y'all like to add anything to that?
Well, I think the bias that people have, it's just something that needs to be overcome. And then frequently the bias is because they are not educated. And so there ought to be effort, from the part of ACOG, mostly probably ACOG, because they have more access to the general OB/GYNs to educate the general OB/GYN sort of the basic ability to take a good history, to do a good exam. Because when you are not knowledgeable about certain things, will perpetuate bias. And the way to get rid of the bias is to educate them. We are not there to make them the best surgeons, because that's not going to happen, because it takes a long time to become good at what you're doing from a surgical standpoint. But yet it doesn't take very long to educate people about listening to the patients, what part of the history is important, what part of the exam is important. And to be honest, when you are doing that efficiently day in and day out, it doesn't take too much time to be able to pick up somebody who you have very, very strong likelihood of having endometriosis. It's just a matter of practice. And then, they just need to be given the pointers. And I'll be happy to provide that kind of education to the general OB/GYN so that they will feel comfortable and be able to recognize and validate the patient's symptoms.
I think it comes back again to that point that Nick raised. Socrates, the one thing only I know, and that is that I know nothing. I've never encountered an OB/GYN who said, wow, this is beyond me, or I can't do this. And that there's no differentiation, it seems, between the mindset of a general OB/GYN and someone like yourself or Nick, who have really got this, expertise in endometriosis. There isn't, on paper, there isn't this differentiation. There is no specialty as there is with oncology, for example.
We really struggle
there is
with
no
that.
accreditation. Everyone is like, any OB/GYN can say, well, yeah, I can treat this disease. I can treat it. I mean, you don't need to go and see Nick. I can treat it. And I don't know how or when that will change. In a way, if there was a recognition of, okay, this is my turf, I can diagnose it, or I can suspect it, or I could do this and that, but this, when the patient falls into this box, this is beyond me, and my best service to this patient is to refer them on. That would be an ideal situation, but it's not obviously happening, and I don't know how we could change things to make it happen.
And it really is an educational gap, because general OB/GYNs have no financial incentive to be doing endometriosis surgery, to be honest. It pays very, very poorly for the general OB/GYN to do it in most cases. And I mean, I just had a patient that came to see me that is going to be having her third surgery in a year, that has stage 4 endometriosis, invasive through the wall of her rectus sigmoid colon. And her general OB/GYN operated on her for a 15-centimeter endometrioma earlier in the year, which already is a tremendous risk factor for very high-grade disease. It would be very unlikely that a patient with an endometrioma that large doesn't have severe pelvic disease. And then when she had recurrence, she operated on her again. And in the second time, realized that she had, really very, very bad pelvic disease invading into the bowel, and then referred her. And I was just kind of dumbstruck. I was like, I don't know. You want to be kind to your referring physicians and say thank you for referring the patient, but at the same time you go, I don't really understand why you're in the operating room the second time after you already saw how bad it was the first time. And I don't know how to get around that when people don't quite recognize that there is a realm that they just aren't really trained in, and that there is another level that they can refer to. That's why probably like 90% of my patients come self-referred from themselves. And if they get referred from another doctor, it's usually because they told their doctor, I want a referral. It's not that often. Maybe 70% of my patients at least, basically come to see me out of their own volition rather than that they were sent by their doctor. And that's part of why I spend a lot of time educating and online, because I feel like the most efficient way to get patients to kind of get good care if they need it is to educate directly to them, rather than spending a huge amount of energy trying to get physicians to refer. But Dr. Lee's comments are very important. I mean, that we can train people better. And And once they do become more educated, they do better. But it takes a lot of energy. It's difficult sometimes.
Well, I think that they would hopefully know when to refer.
Right.
The
Hopefully.
physician that you mentioned about obviously is totally clueless as to the implications of endometrioma. We all know, people who are educated know that the presence of the endometrioma increases your risk of bowel involvement by 5 times, which is obviously significant. But those people who don't know that just don't know that. They just think it's just a cyst, or just operating on the cyst again. And that's what they think. And so if you would have to be able to educate them, they say, well, you know what? Next time I see somebody with endometrioma on ultrasound, it's out of my league, and we need to refer to somebody else who can do it better. And so that's where the power of education, so they know what to look for. But again, as Libby had mentioned, that a lot of OBGYNs suddenly have too much pride, not knowing who the levels they have. And many of them think they are better than they really are, which is probably true. But I think I don't know how to get around that. But for those people who want to learn, I'm happy to teach.
Yeah. I mean, in their defense, when I did a OBGYN residency, I did some horrible endometriosis surgery. I mean, I didn't do it. I was participating in it with attending physicians. And I can remember vividly the surgeries that we did. And I look back and I go, oh my, I don't know what we were doing. We were fooling ourselves to think we were doing anything effective. But I left my program thinking that's what endometriosis surgery was. And it's really only because of like YouTube, I guess, that I learned that people could do it better. I mean, I don't think I ever had mentorship with someone who really could teach me endometriosis surgery. I had mentorship with people that could teach me how to operate, which then I could turn that into endometriosis surgery with studies. So if people go through 4 years of training and they never get mentorship with anybody who's really good at it, then it's difficult. But the good thing is that there's now AAGL fellowships all over the country in a lot of places. And so a lot of residents are getting exposed to more advanced surgery, and they get more advanced diagnostic techniques, and it's getting better. I just feel like things are, we're a world away from where we were a decade ago. I think that there's so much more acceptance now. I think that people generally believe in endometriosis surgery, whereas I think that 5 years ago, people were skeptical, and 10 years ago, a lot of people thought it was charlatanry. And I don't really hear that anymore. I mean, do you agree, Ted? Like, I think that's I think
I would say like a huge percentage of OB/GYN residents will graduate after 4 years of residencies without seeing excision endometriosis. Okay, and that's obviously a big issue, because if you've never seen it, even you don't know it exists. And so you would never know that that type of surgery exists, and people can actually, be able to do a lot of very advanced, difficult surgery for deep infiltrating endometriosis, different parts of your body. And people like do exist, but obviously there are not many of us, and that's an issue. And obviously, as a fellowship director, and then many of my past fellows have gone on to become directors of their own center throughout the country, and they're the one who also continue to propagate some of the skill sets that we taught them. So it's very important. I think educating people about how to do the surgery, educating people how to diagnose the disease is important, because otherwise, and that's kind of hopefully it's my contribution, is to provide access to the people who needed it. But at the same time, I do believe down the road, there ought to be some way to, validate, or some kind of credentialing system where people patient would know that, okay, this is the type of person I need to see to get the surgery done. They're doing that in the UK already, and is supported by the healthcare system. Unfortunately, I think it's pretty watered down version, so it's become too easy to become credentialed in that system. But they got to be at a happy medium where you can have people credentialed to do high-level surgery, at the same time continue to provide access to patients who have mild disease, who doesn't necessarily need to see like the most advanced surgeons. So that way, it's we be able to provide care for more people. Right now, as you mentioned, that the reimbursement for endometriosis surgery is, it's not great, and so therefore it's hard for people to have the incentive to get better at what they do. On the other hand, if you have, if you go out into the private sector where you do fee for service, a lot of patients cannot get access because they don't have the means to pay for the surgery. So they need to be like a way to credential the different level of surgery and be able to provide better reimbursement. Obviously, there's a lot of obstacles. As the future president of AGO, I've been working on this issue, continue to have issues, and I think patient advocacy will have a strong role on this as well. And then obviously, I'm hoping to get the support of the patient advocates to help me to take to the government and be able to maybe come from the top down to be able to enforce some of the changes that we like. We want to make sure that endometriosis surgery is valued. Right now, all endometriosis surgery is valued the same. Whether I spend 5 seconds burning a few spots, from a numerical standpoint, that's the same as if I take off the entire pelvic sidewall, or excise the entire cul-de-sac vertebral septum. That's the same surgery from a numerical value standpoint. And so when your work is not being valued, who wants to be trained in a surgery that has no value? There's no numerical value attached to it. So we need to be able to provide that the time you spend to do the surgery means something, even though if it does not translate directly to the number of dollars, but at least to get a sign of value to the amount of work that's performed.
Yeah, it's a huge problem, and medical economics are completely perverse. Hospitals love endometriosis surgeons because the facility fees are through the roof. And you do these really complicated cases, and they actually do value the way that hospitals can bill an insurance company. If you do a big stage 4 case with a colorectal resection and 4 days of the hospitalization, they're going to get some huge amount of money. If they're paid good insurance, they might get $100,000, but the surgeon will get paid $1,800. And it is, so hospitals sometimes employ physicians, and will pay them reasonably. I'm sure that McGee loves Ted, you being there, because you bring huge facility fees, and so that's why they're probably happy to pay you. But if you're not under the umbrella of a hospital system that is happy about the facility fees you're bringing in, then your professional fees will not even keep the roof over your head. It's drastically less than it would be delivering babies. And it's even less than it would be just doing 5 hysterectomies a day for women that have fibroids, because at least you can do those quickly. Whereas the better you get at endometriosis surgery, the longer your surgeries become, and you may spend 6 hours on a case that will, get paid very little. And it's a difficult problem.
I think part of the issue also, just very quick, sorry, with the majority of patients have a milder form of the disease, and while I think the consensus is that with deep disease excision, well, for the non-specialist, they might say, well, deep disease is untreatable other than with Lupron or with radical surgery to remove the pelvic organs, reproductive organs. But for the in the community where people are more aware of endometriosis surgery, it's a no-brainer that a deep nodule needs to be removed. It can be removed, and it needs to be excised. You can't take a blowtorch to a rectal nodule and hope to have a good outcome. Whereas when you have the more common form of endometriosis, there are the studies on the topic comparing excision with non-excision don't really show a clear picture of benefit of excision over non-excision. Now, there are many reasons why that might be, but that from the perspective of ACOG, for example, where we're talking about the majority of patients with endometriosis, I can see the problem in trying to build the case for why should excision be reimbursed differentially than non-excision for the majority of those cases. I'm not saying I'm not in support of excision for peritoneal endometriosis, just to make that clear, but I'm just being devil's advocate. The situation, it would be very nice and convenient if the studies provided a much more favorable picture of excision over non-excision for those patients. I don't know what Nick and Ted think about that, but I feel like that's part of the complexity.
Yeah, it's sort of the holy grail, and unfortunately, it'll probably never be achieved. Like, I'm not really sure about mild disease, about whether or not excision over, I mean, there's been a bunch of papers that show that for mild disease, that excision, they can't show superiority, and that people will argue about whether the surgeons were well trained and so forth, but nonetheless, it's hard to find a paper that shows that mild disease benefits from excision over ablation type techniques. but then for the other side, the really high grade disease, you can't run a paper of ablation versus excision of high grade disease because you can't ablate it. And you will not find a population of surgeons that are trained in excision who are going to be willing to ablate it, because that would seem just to be completely sacrilegious to us. And so it's almost something that would be very hard to create that study and execute it, and very expensive to do as well. So yeah, it's a difficult problem, but probably we should go on to new topics. But if you just had something to add, Ted.
I think,
Yes.
I think for the most part, I think at least for excision, you get tissue diagnosis. So many patients who actually don't even have endometriosis were labeled having endometriosis, even, but a lot of times they don't even have the disease. And so, because a lot of times, visual inspection will misdiagnose endometriosis a lot of times. At least with excision, you know whether you do or you don't have endometriosis. And I think that's really, even for superficial disease, I think, that having different diagnosis has its value.
So Libby, where do you see endometriosis treatment going in the next 10 years?
It's a difficult question. I think there is, when developing new medical therapies, it takes time. Obviously, Orilissa is the newest thing in the arsenal of treatments on offer by your everyday OBGYN, but among the specialists, it doesn't seem to be quite as popular. Yeah, anyway, we won't go too much into that, but it's very expensive and time consuming to develop new drug therapies because of all the hoops that you have to go through in order to, clinical trials and so on. And I know that there are, I feel like maybe in 10 years, there might well be an accurate diagnostic test that will be able to identify those with the disease, non-invasive diagnostic test, like a blood test or something similar, where, a patient can, or possible patient can do the test, or maybe it's even a daughter of who is at risk, or her mother maybe had the disease before she even has symptoms, could potentially do the test and know, okay, this is something that I will likely, I have, I maybe not have symptoms now, but it's good that I know, and that might help reduce the diagnostic delay. As for treatment, I hope that there'll be a, based on, what Nick described with the AAGL, there seem to be more and more doctors who are at least developing basic skills in excision, or understanding excision is an important treatment to be able to offer patients, whether that's because they believe it really helps or because they realize it's a marketable thing. I think it's becoming more of a, as patients become more aware that that's what they want, then it in turn becomes more popular, even if not all of these surgeons are necessarily offering wide excision. It's becoming like a flat, a hot, it's a marketable term, eye excise. But I hope that that will become more readily available, and that patients will be able to more readily be able to, access the surgery they need. As for non-surgical treatments, it's really hard to know what will become available in the next 10 years. I wonder what Nick and Ted think about that. I know that about new things being developed all the time, or at some basic level, but or being investigated as possible treatments, but then what will actually come to fruition as a feasible treatment option?
Well, I mean, I'm optimistic. I don't know about 10 years, but maybe it will be 10 years. I'm not very interested in new medical therapies that are based on our current understanding of the disease state, because I think our current understanding of the disease state is so rudimentary that I don't think anything you could develop based on what we know right now is very likely to be like highly successful. But I'm really, really interested in understanding the disease better at a basic science level, and what is going on. Why are women getting endometriosis? What is actually happening at a transcriptional DNA level in this tissue, and why is it there? Why is it proliferating? Why is it invading? There are patients that have horrific endometriosis and have no pain whatsoever. There are patients that have horrific endometriosis and they have no pain, but they have infertility. You've got patients that seem to be fertile despite endometriosis, and you have patients that have horrible pain and endometriosis. Like, endometriosis is absolutely not one disease. And I think that when we learn how to differentiate different kinds of endometriosis, we will learn different ways to treat it. And right now we're kind of saying, like, there is no one answer that is correct for everyone. There are some patients that do beautifully on hormonal suppression, as much as that sounds bad to like some of the real hard in the wool surgeon types. If a patient is on hormonal suppression and they're doing great, then great. I mean, I think that's fine. So some patients do great on it. Some patients have absolutely no benefit from hormonal suppression. And there's probably some patients that actually have proliferation because of hormones, that they may actually have progesterone sensitive endo that seems to grow in the face of progesterone. And all of these types of endometriosis are genetically distinct. And where the real future is a true genetic understanding of endometriosis. The lab that I am a consultant to, which is called Juno Biosciences, has identified over 500 genes that are very tightly associated with endometriosis, many of which, if you have that gene, you will have endometriosis. Like, there are quite a few genes, at least 50, where if you've got that gene, you're going to have endo. And what's really wild is that these genes are not all the same. It's not like they all do the same thing or they all follow the same biological pathway. These are different kinds of genes and different kinds of biological pathways that seem to be tightly bound to the disease state. And when you see a biologic genetic diversity like that, you have to accept that endometriosis is not a single disease state. It is a group of disease states, and they look different. But when we can get to a point where we can sequence your DNA and tell you exactly what kind of endometriosis you have, then we can say, you know what, you're going to do great on progesterone suppression. You're going to do great. Maybe you're going to do great with a GnRH agonist. And then, you know, okay, you're a patient that is going to do great with surgery, and you should definitely have surgery. There are some patients that don't seem to do well with surgery. And if I could identify those people genetically up front, that would be great. And I think that's, okay, that's the next step of the future, is being able to differentiate patients genetically. And then we will start to find individual subsets that we can treat genetically, where we can identify very specific gene defects that can be treated. And that might reverse their endometriosis, or it might make them respond better after treatment, whereas you can operate surgically and remove everything they got and then change something genetically that allows them not to have recurrence of either endo or endo-related pain. You know, we're sequencing the DNA of every single patient that comes into our practice and trying to get these answers. And it's interesting. Libby's helping. Libby's actually our research coordinator.
And I'd like to say with the idea of sort of creating identifying distinct genotypes among the patient population, it's not just about endometriosis, but, you know, a lot of patients it's not just endometriosis. Endometriosis is a diagnosis, but they have complex pain for more than one reason. And it's also about understanding, okay, the wider picture of why they're in pain. And a lot of patients will still have pain even after they've had effective excision. That's just one aspect of their treatment. So trying to better understand and predict and fully treat their pain, rather than, because endometriosis kind of gets blamed for everything, but really taking that name away, what you really care about is, I want to be pain-free. I want to be fertile, if that's a concern. So it's really about that rather than specifically the diagnosis per se, I think. I mean, and that sort of often gets neglected, especially when you look at the clinical trials for drugs that are, you know, targeted toward endometriosis patients. It kind of strips away the complexity, of the pelvic pain that many of these patients present with, where, you know, it's not just, there's more to it, and surgery for endometriosis is just one aspect. So getting a better understanding of that.
Yes.
Do you want to add something, Ted?
Yes, did you want to add something?
Yeah, I think, you know, what Libby's saying is true. That it's like, you know, just because you have endometriosis doesn't mean that explain everything, every symptom you have. So a lot of patients obviously, you know, just don't understand that the presence of endometriosis doesn't mean that every symptom you have is caused by endometriosis. And not all the pain that you have is caused by endometriosis. Sometimes endometriosis just can be an incidental diagnosis. You happen to have it, you just have it, and may or may not cause some of the symptoms that you have. So it's very, very important. And that's why your ability to do a good history and do a good exam would allow you to distinguish whether that's a source of the pain or not in a lot of times. So it's very important to do a good exam. And in terms of the future, I think future of endometriosis care, I think the biomarkers for endometriosis, I think in a couple of years, that will be a reality. I think you'll be able to get your blood drawn and be able to tell if you had endometriosis or not. And there are many companies that's already doing that. You know, in terms of the surgical treatment, I think, you know, I think obviously train more people is important, but at the same time, you know, even people who come to AAGO fellowships or different fellowships, there are such a spectrum of different type of training and background some of this fellowship have. So not every, you know, AAGO fellowship will provide the kind of training that you need. So we will continue to work on credentialing in a way that is, you know, is necessary, and then, you know, maybe down the road some kind of the video-based credentialing system will become necessary, because you know, for example, you know, just because you had to pay a lot of money to see somebody for surgery doesn't mean the person is any good, and just because you're a professor of a big name institution doesn't mean you're any good. So right now, none of those means nothing to me. Unless I see that the person operate, I see their surgery, I know that person can do certain things. But right now, that's what the patient's based on. Patient based on, you know, the Facebook reviews, you know, as well as you know, the titles the person has or how much money they had to pay the surgeon. They based on their ability, based on those factors, but none of those are real. So we have to find, we are responsible to find a better system to evaluate and credential people who do endometriosis surgery. And that's the future. We need to do that. We have to do that.
Yeah, I mean, I would add that if I do surgery for someone and 2 weeks after surgery, they write a glowing review of my services for them, as much as that is nice, and I appreciate it, it's sort of meaningless. I mean, they're responding to the fact that I was nice, I respected them, I listened to them, I made them feel heard. They had a decent experience in the hospital or the surgery center. My staff was nice to them, and you know, that's ultimately the experience. The review that really matters is the patient who a year after surgery says that their life is better after the surgery. That's the review that matters, and you don't see that review very often. I mean, mostly people, if they're really better, they probably don't spend as much time on Facebook talking about their disease state. You know, so I'll just take it all with a grain of salt. I mean, I appreciate it myself, but for people out there that are reading reviews, you know, the review that's 5 minutes after surgery doesn't really mean anything. It's really about how even a general OBGYN going in and ablating something, you might feel better 5 minutes after surgery. That's been shown. So, yeah, I agree with Ted. It's hard to judge, but as far as the future, in the end, I think training physicians, unfortunately, it's unscalable. Like, we can't train enough surgeons to, if surgery is the answer, let's just assume surgery is the answer, then we can't train enough physicians to address the problem because it takes too long to train people to be good at it. But I hope for a future where surgery is not the answer, that we actually have a very fundamental way to address the disease state at a very fundamental level, and maybe make surgery less necessary.
And on that note, switch gears. This wraps up the portion of general questions. Welcome, everyone. If you are just tuning in, please drop any questions that you have below. Joy Roberts, the founder of Endotruthslive, is in the comments below as well. She will see and help you out. But we already have some questions that came in or before the show, so we will be hitting those first. So this first question that came in from the community is for Dr. Lee. Sarah asks, she said frequently she sees endometriosis being presented, or she is being told it's presented as IBS. So she is having gastro symptoms during her second pregnancy. She was always going down the GI path with doctors. She's been treated from the GI perspective with no improvement of her GI symptoms. Now, doctor, her daughter is now 9 years old, and she's struggling She says, I have struggled with that this entire time. Obviously, she's forward thinking. So this June, I began having my period every 2 weeks, and I sought out a gynecologist care. During that visit and the pelvic exam, the doctor asked me if any of my exams had been painful. They have been, and additionally asked if I had GI issues. He did an exploratory lap and did find endo on her colon and her her uterosacral ligament. It was also found that she has adenomyosis. So she is having expert excision on November 14th, and the doctor has said that patients who have their appendix removed do better in the long term. Could you explain if you agree, disagree, and why? She is desperate to have some relief for these GI issues. So she's saying that she has been worked up several times. She's had many colonoscopies and endoscopies.
Yeah, so, well, first of all, I think many patients who has endometriosis may have a lot of GI symptoms. A lot of patients who have will complain of pain with defecation. But pain with defecation does not necessarily mean that you have endometriosis of your bowel. Frequently, I explain to the patients that if you have endometriosis, in your pelvis, for example, if you have endometriosis on your uterosacral ligament, the pelvis is shaped like a funnel. It gets narrower towards the bottom. So while patients are defecating and any movement in that area will cause pain during defecations. So a lot of times when they're straining and if you have endometriosis on your uterosacral ligaments, that does not involve a bowel directly, you might have painful defecations. So many patients do get labeled with having IBS. So a lot of times my job is to get rid of the diagnosis that patients don't really have. And so some of the GI symptoms could be attributable to endometriosis, especially lower GI symptoms. In terms of appendectomy, obviously, if endometriosis is involved in endometriosis, appendectomy should be appropriately performed. But if the appendix looks absolutely normal, I don't think there's any kind of study to validate incidental appendectomy at the time of endometriosis surgery. And some may argue, well, if patients have right lower quadrant pain, that they may do appendectomy so that next time they have right lower quadrant pain, they would not be mistaken to have appendicitis. But obviously that's more of a opinion-based, not like an evidence-based kind of practice. But in my practice, if you have endometriosis in your appendix, I remove your appendix. But if your appendix looks absolutely normal, I see no reason why appendix should be removed.
Very good. Thank you for that. Does anyone want to add to that?
I generally practice similarly. There was a paper just published, or it was just an abstract. It probably will be in press that Iris Orbuck, who's a surgeon in Los Angeles and New York, published it. She looked at a policy of removing all appendixes in the endometriosis patients, and there actually were a surprising number of appendixes that had some evidence of pathology that looked normal, and that was sort of in support of removing the appendix incidentally. But you always have to look at this paper methodology. I mean, I'm not sure if you were to operate on 100 women who don't have pelvic pain and removed all their appendixes, how many of them would also find some sort of technical pathological abnormality of the appendix? And so it's unclear whether or not the fact that there's, say, what we call fibrous obliteration of the appendix, is that actually pathological? Is there a benefit to removing the appendix? Some people say, well, that's related to endo, but I don't think that's really well established. So I think Dr. Lee's answer is certainly the textbook answer, is why remove an appendix if you don't need to? Furthermore, if you remove appendixes, if you remove a few hundred appendixes, you're going to have at least one patient that has an abscess. It's probably related to technically how you perform the procedure, but surgery is not complication free. So we, just doing things willy-nilly, given enough population of patients, will eventually lead to some bad outcomes occasionally.
Okay, so let's move on to our next question from Beth. This one is going towards you. Dr. Fogelson, we'll start with you. I had endo excised from my diaphragm and from my gallbladder, and had her gallbladder removed at the same time, as well as a lot of endo removed from her pelvis, and she had a hysterectomy, leaving one ovary. She is still having pain and symptoms. When, how, possibly, could one make the decision to repeat a diaphragm surgery? Also, note her cervical spine is curved the wrong way, and she has a lump between the disc where the phrenic nerve connects. So how can she determine whether or not the neck issues have to do with diaphragm endo?
So complex question, and I'm not going to be able to give you an absolute answer, but first of all, we got to think about how long out from surgery. Because if you go in and you cut on the diaphragm and it still hurts 3 or 4 months later, that is not surprising. I mean, it's going to take a long period of time before you really say, okay, there really is a persistent pain that's not just coming from surgical recovery type pain. If there is persistent pain in the diaphragm, if there was endometriosis on the diaphragm at the first surgery, the question is, was there really endometriosis surgery on the diaphragm? I have operated on lots of patients that have quote diaphragmatic symptoms that have some stuff on the diaphragm that does not pathologically come back as endometriosis. And then they say their pain was better or not. But like that patient, I'm not going to reoperate on her, because unless I found clear evidence of endometriosis, then you're really not going to reoperate. Second, diaphragm surgery is a big surgery, and you really have to have a reason to believe that you might have missed something. I'm not sure it makes sense to go back. I'd be very interested to hear what Ted thinks, what he thinks, because he does diaphragm surgery as well. But I'm not sure if it makes sense to go back on the idea that it's recurred. Now, the one area where I really think that I would potentially consider going back is if the technique of the original diaphragm resection wasn't optimal. And I say that because my own technique in diaphragmatic surgery has changed dramatically over time. I used to try to reach over the top of the liver. I even published a video in the AAGL reaching over the top of the liver to do diaphragm surgery. And I realized that that was actually a fairly suboptimal technique for doing it, because it really limits your access to the diaphragm. And if there were disease that were kind of on the back of the diaphragm, you would miss it. And so what I do now is I put the patient on her side and I actually sever some of the ligaments that connect the liver to the patient, and then it allows the liver to fall out of the way, and then you can see the entire diaphragm. And now that I do it that way, I go back and I say, wow, in the past I may have missed lesions for defects in my technique. And so a patient like that, maybe I would go back and operate. If I really think I did as good of a job as anyone can reasonably do, I probably wouldn't go back and operate, because I just think the likelihood of finding anything is really, really low. As far as this cervical spine phrenic nerve issue, that's an interesting question. I mean, when you get down to a point of questioning whether or not a nerve root is affecting a particular symptom, the fairly direct way to do that is to have a interventional radiologist or a pain management doctor block the nerve root and to see if the symptoms go away, because you could block the roots that you think might be causing pain. And if the pain goes away when those roots are blocked, then it may indicate that that's the problem. Now, it's very confusing because the diaphragm is innervated by the 3rd, 4th, and 5th cervical nerve root. And if you've got a C-spine issue at a particular nerve root and you block it and it gets better, I guess you don't really know if it's at that spot where it's pinched, or if you're just blocking the downstream diaphragm. That's why I can't give you a very specific answer, and I don't even necessarily have an absolute answer, other than to say it takes a thoughtful doctor with some resources for nerve blocks and so forth to perhaps put together a diagnostic plan. Of course, if you block all the C-spine nerve roots temporarily, the diaphragm is going to stop working, because it will well, yeah, it probably would. It probably would paralyze the diaphragm for a while too. So you have to think about that. But I don't have a very specific answer, other than to say work with a thoughtful doctor that might have resources with a pain management physician that could do some blocks as well, and you might come up with a good diagnostic pathway. So often we have very complicated questions passed on Facebook, and I go like, okay, well, this is way too complicated to answer on Facebook. You have to come and see me or somebody who is thoughtful about these things to really dig into it and see if we can figure it out. And we may or may not be able to figure it out, but it's almost impossible to answer it in a very generalized way.
Yeah, I agree. I think it's without seeing the actual like pictures of the surgery, the exposure of the diaphragm, what was actually there before and after, without seeing any of that is very, very hard question to answer. And so that would recommend whoever wrote the questions to get a formal consultation with somebody with expertise in the area.
All right, there you go, Beth. Okay, so moving on to our next question. This one is for Amber, and we will start with Dr. Lee. What are the complications of endo and kidney loss?
Well, so endometriosis obviously can, constrict the ureter. And then a lot of patients who have endometriosis ureter actually do not have symptoms. And then by the time they are diagnosed, a lot of times they have loss of kidney functions. And so it's basically a matter of vigilance in terms of somebody who that have evidence of deep infiltrating endometriosis, or somebody who has presence of endometrioma. Those patients are obviously a higher risk for having deep infiltrating endometriosis. In our hospital, everyone gets a screening renal ultrasound. So if somebody has hydronephrosis from endometriosis, those patients get evaluated, and obviously we're able to save some of those patients' kidney. But a lot of times, unfortunately, the screening renal ultrasound is not done on a broader scale. It doesn't take much for the ultrasonographer just to stick the ultrasound, in the back to look for the kidney. But if more of those done, obviously we'll avoid a lot of the patients lose their kidneys. And then majority of hydronephrosis caused by endometriosis does not actually invade into the muscle or the actual muscle layer of the ureter, and simple ureterolysis free out the ureter from the surrounding fibrosis is enough to restore function. So you don't need to do ureter anastomosis, or you don't need to do reimplant the ureter to the bladder for the majority of the patients. So the surgery for it can be actually not that difficult, but dictation is the important part.
Okay, unless anyone has anything to add, Michelle has a question, and we'll begin with Libby. Y'all good? Okay, so Libby, Michelle asks, after my last laparoscopy, they said that there was no active endo. So what could this mean? Because I'm still in pain 2 years later.
So my thought is when someone is told they have no active endo, it can mean one of two things. One, they mean that they didn't find any endometriosis. They just found evidence for, of scar tissue perhaps, or reperitonealization from previous excision where the peritoneum has grown back and looks slightly abnormal. So no endometriosis. Or it might mean that they saw what they think is endometriosis, but they have assessed it visually as being inactive because they think it's burned in or burned out, which is terms sometimes used. Actually, there's a study that was kind of relevant to this. Just pull it up. It's from 2014. Correlation of histological and macroscopic findings in peritoneal endometriosis. And what they looked at were the sort of morphologic findings, so how the lesions looked and how that correlated with the histological findings in terms of the presence of disease and how active the disease was. And they actually found that you can't predict how active the disease is based on how it looks. So if a lesion's red or if it's white or black, it doesn't predict how active the disease is. So reaching the conclusion based on just looking at a lesion, oh, that's burned in, so that's not relevant because it's inactive. Unfortunately, that seems to happen, but it shouldn't be treated that way because it doesn't necessarily say anything about how active that lesion is. It might speak to how old a lesion is. So we find that younger patients tend to have more red and clear lesions, and older patients tend to have more white and black lesions, relatively speaking. However, we also don't know, there's a further step. Even if a lesion is histologically speaking active, we don't know what that means in terms of what the patient's experience of that lesion is, if it's causing pain or not. A lesion might be very active, but might not be causing pain. A lesion might not be very active, but might be a source of pain for one reason or another. So the point is, there's one assumption: this lesion looks like this, therefore it's inactive. That's a false assumption, because it doesn't actually reflect on how active it necessarily is. And secondly, the assumption is, okay, if a lesion is active, it therefore is potentially painful, it's clinically relevant. And if it's inactive, it's clinically irrelevant and doesn't need treatment. That's again a false assumption, because we don't really fully understand what lesions are hurting and what are not. We can, know a patient might say, well, I have pain on my left side and there's disease on her left side. So one might deduce that that's causing the pain. But, short of removing the lesions and seeing whether that helps reduce the pain, there's not really an easy way to just look at someone's pelvis and say, oh, that disease is a problem and that isn't. So I'll just remove that lump there and I'll leave that lesion over there because it's fine. So that whole mindset is problematic. Now, whether that has any relevance to why this patient still has pain 2 years later is another question, and that would probably need to be reassessed and, tried, with an exam and with a history and so on. It may or may not be due to endometriosis. It may be due to something else. And that's kind of another complex question. But the point is, if there is tissue that's abnormal and someone's doing the surgery to, potentially treat abnormal tissue, it's probably best they don't jump to conclusions about whether that tissue is clinically relevant or not before just removing it, because that's really the only way of knowing. Obviously, I'll let the doctors put their input, but that's what I understand of it.
Libby, I like your answer, because that's kind of refer back to what I just said before, is that just because somebody has endometriosis doesn't mean that's a source of the pain automatically. So if that was never the source of the pain to begin with, you can excise all you want, you can do the most perfect excision ever, and patient will still in pain. And so now the next person goes and says, well, there's no active endometriosis, there's no sign of endometriosis. Perhaps you think about whether that's the source of the pain to begin with. And so while endometriosis is a common source of patients' pelvic pain, but that's not the only reason for patients' pain. And sometimes patient needs to understand that. And it's difficult because, patient now was told that they have endometriosis and they have grasped onto that reason for their pain. And it's hard for us to take it away, because now they are so, kind of associate themselves with endometriosis now, that for them, they identify themselves with being the endometriosis patients, and you take that away from them, it can be very devastating, actually.
Yeah, I like both answers and agree. I think the thing that we really have to keep in mind is that, if people have endometriosis and they have a excision by a competent physician, and again, it's hard to judge exactly what that means, but if they have recurrent pain, the first thing shouldn't be, well, you must have missed some endometriosis, or there must be some endometriosis grown back. And as much as I like a lot of the online resources, one of the messaging that I don't like is that every patient that has recurrent pain, A, they must have missed endometriosis, and B, they need to go and have another surgery by a better surgeon. And it's really not true. I really feel like, if you had a good excision surgery, if I ever operate on someone that had an endometriosis surgery by someone who's good, and that I know what, that I look at, like I look at the video or I know who did it, I almost never find endometriosis. Or if I find it, I find like some tiny little bit, you find, and a lot of times what you find is a lot of scar tissue, and believe me, that scar tissue is a whole lot harder to remove than the endometriosis was in the first place. And when you remove all that scar tissue, it's almost never pathologically positive for endometriosis. And furthermore, the patient doesn't usually benefit from that surgery very much, which is, I'm not very aggressive about going back and removing the scar tissue left over from other excision surgeons. I just haven't found that very clinically useful for my patients, and it doesn't come back as endometriosis. And so you have to just look at other things. Now, if a patient has excision surgery and then they come back and they have a very, very specific complaint, I mean, I'm going to ask them very, very specifically what they're feeling. I mean, when someone says I'm in pain, I'm like, that's way too general. I need to know exactly where you're hurting and where's it going and when does it hurt, because they may tell us that they actually have a constriction of a particular sacral nerve root, or maybe they have a vascular constriction. This is kind of where neuropelviology comes in, that they may have a very specific identifiable source of that pain that we can determine through very detailed history. And that might lead us to do something surgically that wasn't done before, or potentially just to go a little deeper. And we can't address, there may be certain surgically addressable sources of pain that can't be addressed just by, I'm going to go in and remove all the endometriosis. So, you know, we do try to find those few patients that, and there aren't a lot of them, but the few patients that maybe really do have a very specific pain syndrome that might be addressable surgically. But there's other, you know, there's other issues. Pelvic floor is under addressed. I mean, I think every single patient with chronic pelvic pain should have a relationship with a pelvic floor physiotherapist. I think that Botox in the pelvic floor is very helpful. I think people have pudendal neuralgia, people have interstitial cystitis, and then there are probably other pain conditions that we don't even fully understand. I mean, pelvic congestion syndrome is another one. So, and then there are probably a bunch of things that we don't even have names for, that we don't totally understand why people have pain. So it's complicated, unfortunately.
Okay, Dr. Lee, I have a question for you. Jennifer asked that her daughter is 12 now, been on her period suppressing drugs for a year after showing signs of endo. It just started to stop working. So what should my next step be with her considering her age?
Well, that's a very, very tough question. I think although they are patients who have endometriosis at a young age like that, I think there are potentially other issues that you have to consider. But of course, you know, it would be not unreasonable to at least do a diagnostic laparoscopy to document whether endometriosis is present or not. And then so it's I think a reasonable diagnostic laparoscopy would be the first line, just to take a look to see if the patient has endometriosis, especially if given that the oral contraception OCP is not working anymore. And I think it would be reasonable to go in and take a look. But obviously, in somebody young like that, you do have to look at other factors as well. Some of social, psychosocial issues that may be in the background that you're not aware of, maybe need to be investigated as well. Potentially history of sexual abuse, stuff like that. That's a possibility, not necessarily, but something you have to keep in the back of your mind, especially for young patients like that. So I think this is like something that would require some collaboration with the pediatric gynecologist, as well as endometriosis specialists, that both of them have to work with these patients.
Okay, thank you for that. Okay, back to you, Dr. Fogelston. Alicia, she asked, is there a clear way to biopsy the uterus for adenomyosis? So someone can decide prior to surgery if they want to go forward with treating it.
I mean, you could, but we don't. I mean, is that possible? Probably. But honestly, it's not in practice that people do that. I mean, you could have an interventional radiologist biopsy the uterus. You could potentially even do it transcervically with something called a true cut biopsy. It's what we use to biopsy solid tumors. But honestly, no one does that. I've never heard of anyone doing that. Imaging is fairly reliable at finding adenomyosis. But I think the thing that's important is I think we're pretty good at determining whether or not someone has uterine source pain. And by that, I mean, if I have a patient that says she has central pain that radiates into her back and the severe cramping in the lower pelvis, and you do a pelvic exam and their uterus is tender, and you examine the uterus, and when they feel pain, when you kind of push on the uterus and they say, that's the pain I feel, it's just even more intense during my cycle, then I don't really care whether she has adenomyosis or not. I mean, her pain is coming from her uterus, and removing the uterus is going to make that pain go away. And so kind of whether or not there is histologically adenomyosis I'm not sure it really matters. I'm interested in what Ted thinks too, and Libby as well. And so, like, I wouldn't be so hung up on whether or not there's a pathologic adenomyosis. What I would be hung up on is A, do you need your uterus for reproducing? If so, don't take it out. If you don't need your uterus for reproducing, then the question is, do you have uterine source pain? And if you have uterine source pain, then a hysterectomy is something to consider. And whether or not it has adenomyosis or not, like if a patient has uterine source pain, I do a hysterectomy, they feel better, and the pathology report doesn't come back with adenomyosis. Does it matter? I don't think so. I mean, they feel better. So that's what I would say. But as far as can you biopsy it, in theory, yes. Does anybody do that? No, not that I have ever experienced.
I agree with Nick. I think, you know, obviously when we do our exam, we do a very compartment specific exams, you know. So if I'm able to reproduce patient's pain with palpation of the uterus, and the patient told me that's where my pain is, I reproduce her pain, I feel pretty confident that a hysterectomy or Mirena IUD may be potentially a treatment for their problem. And whether the pathology comes back adenomyosis or not, it's irrelevant to me at that point. Certainly you can do like MRI, which has pretty good, you know, in terms of, you know, sensitivity and specificity for adenomyosis. But obviously it's a, you know, expensive procedure that I'd rather reserve those patients for patients who really need it, like patient with deep infiltrating endometriosis.
All right, everyone. So we have about 5 minutes left here live with you. I do have a couple of questions, but I'm going to shoot for one for time's sake. And also, we will be announcing our winner of the giveaways. So don't go anywhere. We've got one more question and those winners. So this question will start with Dr. Fogelson, but we would love to hear everyone's response. So Danielle asked, does chronic pelvic congestion need treating?
So it's a difficult question. I mean, the answer is, I guess, no. I mean, if you have evidence that a patient has pelvic congestion, but they don't have any symptoms, then they don't have a problem. Pelvic congestion syndrome, a syndrome being a constellation of symptoms that tend to be seen together. The very definition of syndrome means that there's not a very specific diagnosis. It's a group of symptoms that come together. So if a patient has pelvic congestion syndrome, which means that she has severe, heavy feeling pain in the pelvis, a very dull ache in the pelvis that is present when she's standing upright for long periods of time, gets better when she lies down, doesn't wake her up at night, and she has radiologic findings consistent with pelvic congestion, which is a certain dilation of the real focus in the IR literature is on the gonadal veins, but I actually think that we need to focus on the big pelvic veins as well, which is not well documented in the radiology literature. But if she has evidence of abnormal pelvic veins, and she has those symptoms, then treatment, you know, it should be considered. If she has, like, someone does a scope and they see really big fat ovarian veins and maybe they see big pelvic veins, but she doesn't have characteristic symptoms of pelvic congestion and her pain doesn't get better when she lies down and it wakes her up in the middle of the night, then as far as I'm concerned, she doesn't have pelvic congestion syndrome. And I would not go in and ablate her veins because I don't think it's going to make the pain better. The pain's probably coming from something else.
I think pelvic congestion syndrome in my mind is almost like, you know, it's basically in the same level as ovarian cysts, right? Many of our patients was told that they have ovarian cysts when they have pelvic pain, and the doctor doesn't know what's going on, so they just tell them that they have ovarian cysts because they don't want to sound stupid. They don't want to say, I don't know what's going on. And pelvic pain congestion syndrome is basically in the same class. When somebody stick a scope in there, they don't see any endometriosis, they don't see any other reason for their pain. They don't know even how to do a right exam for the patients. They're basically depending on a diagnostic laparoscopy to solve all their diagnostic dilemmas. When they go in there, they see nothing, and they see some dilated veins. Instead of telling patients, I don't know what's going on with your pain, they just tell them that you have pelvic congestion syndrome. And that's something that we see quite frequently. And so the solution to the problem is if, to teach people how to do the exam properly. And that's really the solution to all this pelvic congestion syndrome that people proclaim the patient have when they don't really have that problem.
I mean, fortunately, there are people that are quite expert in PCS. I mean, I work with an interventional radiologist in town who focuses on women's health interventional radiology, and she's read every paper there is on pelvic congestion syndrome. She knows a lot more about it than I do. So just like the general OBGYN should refer out to me or to Ted or someone like us for endometriosis potentially, I don't try to make the diagnosis of pelvic congestion syndrome because it involves elements that I'm not expert in. I'm not a vascular doctor. So I send her to go see the person I send, who's Mary Costantino in my community, but hopefully there's a good radiologist in a lot of communities. And then she'll look at the imaging. She'll, get into the history in a really detailed way. And if the patient is appropriate for treatment, she'll consider it, and hopefully that's what, you have a lot of resources. It doesn't all have to be fall on one doctor, but it certainly shouldn't fall on a general OBGYN to make the diagnosis of pelvic congestion syndrome, because it involves all kinds of elements that are really in the realm of vasculopathy and interventional radiology and vascular surgery that they're really not trained in.
Well, the thing is that, I see many patients who come in with been told they have pelvic congestion syndrome, including ones that already have radiologic studies. And when I see those patients and I examine them, when I palpate the uterus is enlarged, it's focal uterine tenderness, it's very, very consistent with endomyosis.
Right.
And, and so those patients, if you know how to do the right exam and be able to feel confident the source of their pain, then all of a sudden pelvic congestion syndrome may or may not be there, even though there may be radiologic evidence of it. But just because you have radiologic evidence of something doesn't always mean that's the reason for your problem. Just because you have endometriosis doesn't mean that's the reason for your pain. So that's why you have to kind of think in a more of a global, holistic fashion to take everything into considerations, not having one test to tell you that's what you have. Everything has to match. And that's really the ideal patient that we're looking for, is that perfect match of the symptom, the exam, and then the findings in laparoscopic surgery, or finding in whatever radiologic studies we do. So everything has to match, and that's really the ideal patient that we want to see.
All right, well, we'll end it on that note. I want to thank everyone again for sitting down and tuning in with us today. It is always an honor to sit down with you, doctors. Libby, always a pleasure. And
thank you.
Thank you for inviting me.
Thank you.
Absolutely. Thank you endlessly to Endotruthslive founder Joy Roberts for putting the last event together of 2019. If you have any additional questions, you can send them to her. She'll get them going for next year. But I did want to let everyone know we have our winners before we let you go. We had 2 giveaways. Our first giveaway winner will be Alicia Landis, and our second is Jennifer Haas. Please message Endotruthslive to claim your prize. All right, guys, y'all have a wonderful day.
Bye-bye.
Thank you. Bye-bye.